What I'm going to talk to you today about is the face transplant that we did at the Cleveland Clinic. Transplantation goes back, at least as far as we can find in literature, it goes back to about 300 or 400 AD. And the story of St. Cosmas and Damien, where they took the leg from the one gentleman who had recently died and put it back on the person with the infected leg. With the way microsurgery has gotten, we've been able to take a part that's been cut off and put it back on. You can see this gentleman cut his thumb off using a table saw, and then we put that back on using a microscope and hooking up his arteries, veins, nerves, and tendons and bone. So at any time that we try and put tissues from another person's body on your body, what happens is your body is designed to prevent infection, attack anything that's foreign to your body. Your immune system will take and cause a rejection, and if you put a kidney in, if you put a face on, anything like that, and you didn't give that person any kind of medication, that part would turn black, fall off, and it wouldn't work, or it would die. The first advances came with medications. We finally figured out back in the 1950s ways that we could modulate, or ways that we could cause the immune system to prevent the rejection of the organs. The first two drugs, prednisone and Imuran, were the ones that we had available to us. With those, all the transplants became at least a possibility. So back in 1950, finally we were able to use these drugs, and someone was able to get a new kidney from someone else, and it worked. That opened a flood of other transplants. We can now do liver transplants, lung transplants, heart transplants, pancreas, bowel, and as you're going to see today, we can also start doing composite transplants. Composite transplants are transplants that include more than one tissue type. So when we're talking about doing a kidney transplant or a liver transplant, we're talking about one organ system. When we start to talk about a composite transplant, we're talking about an external thing, like a hand, where we have skin, we have bone, we have nerves, and then finally a face, which is at this point the most sophisticated type of transplant that we can do. The person who came up with the concept was Dr. Maria Semenoff, who is a part of the Cleveland Clinic. A part of her training was to do microsurgery. Microsurgery is really the field where you'd put those organs back on, you hook up tiny blood vessels, and you get them to work again. We can also move other parts of your body in the same way that we're able to put a thumb back on. We can move other parts of your body up to the face to try and rebuild them. But the bottom line is, nothing else in your body really looks like your face. So the only way to replace a face is essentially with another face. So the solution was face transplantation. Putting a face on is a whole another magnitude of difficulty. We're now dealing with multiple blood vessels. We have to get blood flow that goes not just to one part, but it has to go to an entire face for everything to work. So we needed drugs that were going to be very strong to prevent the rejection, but at the same time not cause too many side effects. So what Dr. Semenoff did was, first she did leg transplants in rats way back in 1994. In 1998, she started to do face transplants on rats. Here you can see an example. And to do that, all this has to be presented to what's called an IRB, which is a review board at each hospital that determines whether the research makes sense, whether we're going to benefit a patient enough that we really should be doing this research, and is the cost to that patient reasonable for what we're doing. So how do we determine who's a candidate for surgery? We need to find someone that can put up with a surgery that can last hours, and then we need someone who can heal their wounds. They have to have good nutrition, and they also need to be able to tolerate the medications that we're going to give them. So we did find a patient. Before we ever got to the point where we were going to do a face transplant on her, though, we had to try everything else. We had to exhaust our traditional means of reconstruction to determine if it made sense to try a face transplant on her. Here we have a CT scan, and you can see in the forehead of the patient, it should be nice and smooth everywhere. You should just see smooth bones. What you see is bones missing, bones fragmented, and on the left-hand side, this is like taking a slice through the face, so she's really missing the whole mid part of her face. And here you can see, after we've done some reconstructive efforts, she had multiple procedures to attempt to get her to look as normal as possible and to heal and to be able to get on with her life. And so instead of looking better over the years with multiple procedures, Connie actually looked worse. What I want you to notice is the front view, how it looks like she's collapsed up, and on the side view you can see that she's completely missing the nose and everything is missing in between. So what we did is we assembled a team. We needed anesthesiologists, we needed experts in transplantation. The plastic surgery group is the group that ran everything with Dr. Simonov in charge. We also had a 3D model made. In the 3D model, I'm going to show you and point out what's missing. This is the model of Connie before she had her surgery. And so you can see that from top to the bottom of her face here is completely scrunched up, and that's because she's missing this central part here. This is actually a model of Connie's face afterwards. And what you can see is now the mid part of her face, this part, this section that runs right here, is now the back. This is the donated patient's face. So as we look from the side, you can really see what was replaced there. Some of these parts you see in purple are parts that we had to remove to get the new face to fit. So on December 17th, 2008, everything kind of came together. We had our team ready and we went and did the first face transplant. The first part you saw was the tissue that we had to remove, and you see also the tissue that we removed that we end up doing from our reconstructions. The final part is bringing the new transplanted face in, hooking up an artery and a vein, and then hooking up the nerves. And we did that on both sides of the face. So we used the microscope to do all of those. And this animation is, again, this is showing in a little bit more detail how we lifted the face from the donor. So incisions were made all the way through. Cuts were made in the bone up on the nose, behind the eye, down on the cheekbone, and through the palate, the upper roof of the mouth. And you can kind of see how those cuts were on the back side of that tissue. So we're going to zoom in again. So under a microscope, using a suture that's actually smaller than your hairs, we sewed the blood vessels together, like putting two tubes together. And we did the same thing for the nerves. So that little white thing that popped in there was a nerve. And the nerves are necessary so we can get Connie's face to move again. Everything went beautifully. Connie's face turned pink, and we were all thrilled. Everything worked as well as it could work. From there, although we were all tired, we had to continue because the work was really only about 3/4 done. What we now had to do was do all the fine work. We had to make sure everything fit just perfectly. We wanted to make sure the skin fit as well as it could, and we had to make sure that everything worked well. And remember, I also said that we had to hook up nerves so that Connie's muscles would eventually work. So we still have some work to do. It really is quite dramatic from the side. So you can really see what Connie was missing and what she got back from the face transplantation. She's breathing on her own. She can eat on her own now. She can smell food again and enjoy food for the first time in years. And again, she can go out in public.